Welcome to the Real Integrative Medicine podcast. I'm Dr. Jordan Robertson, and I'm here to bring you the tools, insights, and strategies to take your health to the next level while using evidence-based integrative medicine. What's real? This is what we want to explore together. Research is ever-changing and not easy to interpret. We're bringing you the best that integrative medicine has to offer while sticking to the facts. Our mission is to elevate the practice of integrative medicine for clinicians and patients alike. Preventative solutions, nutrition, exercise, and sometimes supplements have a seat at the table in medicine, but only if we uncover real science-backed solutions. It's time to uncover what works and challenge what doesn't. Let's unlock your full health potential with an integrated approach. Ready to learn what's real? Let's dive in. All right, welcome to another episode of the Real Integrative Medicine podcast. Today, we're going to talk about what is arguably the most common endocrine or hormone concern in female patients. We're talking about PCOS, and I've invited one of my colleagues and friends, Dr. Mélanie DesChâtelets, to join us today, who has so much to offer on this conversation. Mélanie, I'm so glad that we have the opportunity to spend this hour together and to talk about getting an accurate PCOS diagnosis.
Yeah, absolutely. I'm super thrilled to be here and to share this conversation because I think that it's an important one. It's really like the first step because you want to make sure you're doing the right thing for the right thing.
Yeah, and I've always loved working with patients with PCOS. Even when I got really down the path of like evidence-based women's health, this was where I spent the majority of my time when I first started my practice because of how much we had to offer. I never barked up any trees where the evidence was so clear for conventional medicine and I had really nothing to say. PCOS has always been, it's always had this special place for me where one, I think we do a great job of assessment in integrative medicine because we have more time to spend with our patients. But also a lot of the solutions and treatments do come from sort of that integrated or naturopathic perspective. I would love to hear your story and how you got to this place of this being like the primary focus of your practice and how you support people right now.
Yeah, absolutely. I am a BC licensed ND who does mostly virtual with an office in Burnaby, and I've been practicing since 2010. And to be quite honest, I didn't go straight into PCOS. Had a very general practice, but just felt really drawn to PCOS. One, I have it, so obviously there's a personal bias there, but I don't think that makes me the best guide. I think it's because I know how different it can look like in different people and how different that journey can be. And I was seeing a lot of maybe like weight bias or stigma. And I was seeing it on both ends of the spectrum, maybe smaller PCOS people not getting their PCOS treatment well supported because they were in a smaller body, and also larger body people with PCOS not getting comprehensive care. And I don't think that's intentional. I just think it's a condition that's not that amenable to a 7-minute visit. It's just hard to do it well in 7 minutes.
Yeah, and I would say I think there's been some benefit to, widespread online information about PCOS, but I do think that there's still a lot for the average person to learn about this condition, like how it starts, what the underlying risk factors are, and then how we actually go through that assessment process. I think one of the challenges we've always had with this condition is that it often is appearing at a phase of life where menstrual irregularities can happen, right? If you are 14, your period may not be particularly regular, whether or not you have PCOS. And also, this is a time when people are often looking for contraceptive solutions and other things that will change the way we interpret or think about their cycle. Can you walk us through sort of like the basics of PCOS in terms of like what is actually happening? And then we'll move into how people can understand the assessment or how to get diagnosed.
Yeah, absolutely. It's And I think that's the reality is like there are just some conditions that are a bit more straightforward to diagnose, X equals Y. And so it's very clean and quick and easy. And PCOS is not that. And even the diagnostic criteria is changed based on how old you are. And even what tools we can use to diagnose change based on how old you are. And then you do have that added like layer of like whether they've been on the birth control pill and how much are we blinded to the history of what is menstrual irregularity for that person. So PCOS is considered like a hormonal condition. So I know it stands for polycystic ovaries, and it's kind of a misnomer. It's really about the hormonal condition associated with that. Um, and and so I think that's where it gets a little bit messy is the different age cutoffs and like what we can use and what we can't use and all of that. So do you want me to walk you through a little bit of that? Yeah. Okay.
Yeah, I think that would be super helpful, especially for people who either have been given an assessment and diagnosis recently, and maybe there's new criteria being used and they don't understand why they do or don't qualify any longer. Anytime there's a change in diagnostic criteria, we start to like capture different people than we had before. And sometimes that can be confusing for the average person where suddenly they're like included in a population or maybe excluded. So yeah, I would love if we could just talk through what that criteria is right now and how people get assessed.
I love it. And it's like everybody that comes to see me obviously tend to come because they self-identify as like highly suspecting they have PCOS or been diagnosed with PCOS. And the first visit, I'm like, we're just going to double check. And I always frame that with like, hey, your doc did the best that they could with the information they had at that time. There's just been so much evolution in our knowledge of PCOS over the last little bit. And so now we have different diagnostic criteria based on age and different definitions. And so we have kind of this adolescence, 19 years old and under, and then we'll have like the adult diagnosis. So in our adolescence, we cannot use ultrasound or AMH as a marker because it is a normal finding in that age group. And so many people I have seen get diagnosed based on that in that age group. And that is the biggest rationale for their diagnosis. And I'm like, if you've had an ultrasound and you were 19 and less, like just almost pretend it didn't happen. Okay. So the way to get diagnosed if you're under 19 is you need to meet two criteria. You need to meet having irregular menses, and you need to meet having the criteria of androgenic symptoms, which would be defined as like acne, kind of hair loss here, or excess hair. And when I say acne, also not like your average teenage acne, like severe acne, more persistent acne that's not responding to normal treatment kind of acne, maybe acne on the back kind of acne. So you need to have those two criterias. If it's kind of ish or we're like not sure, we would diagnose PCOS like somebody's at risk and to maybe reassess by using the ultrasound at a later date when they are 20 and up. So that alongside, and always, just because I see this, at least part of the exclusion criteria very frequently get missed, the PCOS diagnosis involves meeting inclusion criteria. You have to have those symptoms, but there are other things that look exactly like PCOS. And so we got to rule those out. And so that blood work has to have been done. And also that history has to have been done, because if somebody has an eating disorder or it has a relative energy deficiency, that can also manifest as irregular cycles. And so also the time to kind of have some of those more sensitive conversations too with our adolescents.
Yeah, it's interesting because a lot of those things can show up in adolescence and be part of that normal adolescent
growth experience that they have during puberty, right? They have that sudden change in hormone status that can precipitate acne. But that sort of like typical teenage acne, one thing I always thought was helpful, and you can correct me if I'm wrong, is that if it's like responsive to sort of regular acne treatment, whether that's, topical treatments or whatever, that typical acne in adolescence generally responds when we treat it. And acne that patients may have that has an underlying cause from PCOS is a little bit more treatment resistant. So it's harder to treat. It's maybe a little bit more aggressive. It maybe scars more often. It's less responsive to the normal things that we would do to treat acne.
Yeah, exactly. And this is where, it's important to have a great conversation with your clinician, because there's not really like this validated, like, exact line you have to kind of cross. And so it's, we have to kind of take all of this information into context to kind of assess those things.
It's interesting. I was going to say that I finished practicing right as the, more knowledge was coming out about young women having PCOS. And I almost had to like convince some of my patients that their daughters probably didn't have it, right? Or that they were having a sort of typical teenage experience with maybe one or two irregular cycles, but then getting back on track and having a typical teenage acne experience. And so I thought it was such an interesting piece, because maybe 15 years ago, I was trying to pull people across the finish line for diagnosis. And then towards the end of my practice, I was like, no, don't worry. This is not PCOS. This is like, it's a typical teenage experience.
Yeah. And then, do you have any other questions about adolescence that you want us to kind of, because I'm like, we can go into the diagnostic criteria of adults and how that's different.
Yeah, let's talk about the adults, because I think that's a helpful contrast for why we maybe don't do the ultrasound in younger patients.
Yeah, exactly. And so, to be clear, what I said is like, it can be a normal finding in that age. So like you can find ovaries that meet the criterias of morphology, but it's not in that age. But as adults, the inclusion criteria has changed. And so you need 2 out of the 3. You do not need all 3. So we have irregular menses, either symptoms of high androgen, so the ones that we've all talked about, or if that's negative, high androgens on blood work. So we would spot it there. So one or the other. And if you don't meet these 2, because if you do, then we've got it right out. Even in an adult, we may not need the ultrasound. But if we don't have these 2, or, we're kind of in the ish of like, is this severe enough? Then we have like the ultrasound that we can do. And what's really kind of novel, and I'm excited because I think obviously whenever we have like a technology that can sometimes be a barrier to access, is the guidelines even recognize the blood work of AMH. People with PCOS tend to have a higher AMH than their non-PCOS counterparts as adults. Now, we're still kind of wrestling it out. It's like, what exactly is that number? And so I think that with time, we will get a little bit clearer. I think we have hints, but it's still a tiny bit of a wrestling match, that it's like not in the guidelines where it's like, an AMH of this equals that. So 2 out of the 3. And the third new option in adults is either a positive ultrasound or an elevated AMH. Could get that 2 out of 3. And the exclusion criteria still need to happen for adults.
And what are we excluding there, Melanie? Like, what should people be mindful of that they're getting tested for to rule out as part of their PCOS assessment?
Yeah, absolutely. So, I mean, thyroid is probably the most common and obvious one. And I do find that this frequently gets done. This is rarely missed, but if somebody's thyroid is off, that can look like irregular menses. And so that's not a true PCOS, irregular menses. But there are a few others that I do see get commonly maybe missed in the workup. It's the ones that I kind of catch the most often. And to be fair, they're less like frequent. They're less frequent. They don't happen as often, but because it looks like exactly like PCOS, we have to test because we have to catch these people that have these other things, even when they're rare. And so, some people have like a slight genetic thing with their adrenals that creates a bit more androgens and can look exactly like irregular menses and high androgen symptoms. So that's another one. FSH is kind of like the communication between your brain and your ovaries, and kind of checking in on that can be helpful, because if we will sometimes see in energy restricted situations that being altered, and that would change someone's cycle. So those are some big ones. Looking at, in some cases, cortisol when that's relevant, and in a small group of people. This doesn't need to be excluded for everybody, but maybe even assessing for Cushing's if there's some extra symptoms there. And if the androgenic symptoms come on really suddenly and really severely, then there's also some like rare tumors and things like that we should have on our radar to make sure have been ruled out.
Okay, that's super helpful. So, and I think like it speaks volumes to this like need for a practitioner, right? So all of those things that you just listed there, like that's not something that you can do a quiz on TikTok about, right? That's something that you actually need someone to assess, do the labs, and then help you interpret, especially since it's a slightly gray around some of the interpretation around those pieces, right? If that we are not if AMH isn't yes, no, right? That there is a range that we're looking at and maybe curious if your levels are high or low. There's other aspects of that assessment that needs to be looked at in context. But most of the rule outs just straight up need blood work. And that's not something that you can self-diagnose or self-rule out. And so it's so important that you're working with a healthcare provider in order to do that.
But often, like, because some of them have like genetic basis, they just need to be done once. And that's why I'm always like wanting to review past blood work. So I'm like, maybe it was done and I won't need to do it again, right? These aren't like ongoing things. It just makes us feel better that, those inclusion criteria are truly due to PCOS and not another cause that looks like it.
And how often do you see, Melanie, because PCOS responds in many individuals to lifestyle changes and nutrition and exercise, like how much can people exercise and eat their way out of meeting the diagnostic criteria? Like, do you see that often in practice? And when people have maybe masked aspects of their PCOS with like ultra healthy lifestyle, or that they've implemented some things, how often is that getting in the way of us understanding someone's underlying PCOS?
Yeah, totally. I mean, because we know that, like these factors, when we look at them in research, will help with menstrual regularity and all of the things that we were just talking about here. And so it is. And that is when it gets a little bit tricky, is like when you have maybe that person with a really healthy lifestyle that has those really strong androgenic symptoms that are persistent, that are severe, and that might be your at risk as an adolescent person. And then your person who, once they cross that 20, you look for the morphology on the ovaries to see if it's there. And maybe if that person was in a larger body, that we would also see the irregular menses, but we're not when they have the lifestyle that they have. And so that is also a positive factor, though, because it's like that is why lifestyle is first line in PCOS, and that's really cool, and super passionate about that, and why anybody who gets diagnosed at any age, that still's got to be part of the foundational pillar.
Mm-hmm, mm-hmm. Yeah, it also makes me think, so like on the other side, when people are taking medications that may influence that diagnosis, and I think the birth control pill gets such a bad reputation online for masking symptoms or covering up someone's
Yeah.
experience. And so, I will start this by saying that I personally am very pro oral contraceptive when it's helping support people's reducing their risk of an unintended pregnancy. But also, the pill does solve some of the symptoms associated with PCOS. And depending on your age and stage and the importance of those symptoms and the consequence of those symptoms, it can do a beautiful job of decreasing acne and supporting mental health in young women. It can do a great job of preventing endometrial hyperplasia or overgrowth of that uterine lining because you're not ovulating with regularity. But when people are put on the pill during that sort of like, we'll say critical window or that sort of puberty-ish window, what influence is that having on our ability to diagnose them appropriately? And how does someone who's been on the pill for a long time even start to think about their PCOS assessment?
Honestly, that's a tricky question, right? I mean, we would anticipate, I hate the word kind of the pill regulates the cycle because I'm like, it doesn't regulate the cycle, but it is inducing a very predictable withdrawal bleed for most women, which has a huge quality of life benefit. And by its impacts on the sex hormone binding globulin, which is something essentially that helps to kind of, if you want to imagine like a sponge kind of just sucking up the rubber duckies so that the rubber duckies aren't like available to affect the tissue. Think of the rubber duckies as like the testosterone. It keeps it bound up. And so the pill does that. And so people's androgenic symptoms tend to get better. And so when somebody does go on the birth control pill, we would anticipate androgenic symptoms to be better. And we would expect, that there would be a very predictable withdrawal bleed. And so in the guidelines, it kind of says like, yeah, this is something that should be offered to someone with those two things where that's a quality of life issue. And, but also it does state based on patient preferences and values, right? And so I think I classify myself as like not anti-pill, not pro-pill, but like pro-conversation about the pill. And I think that's the part that's missing. And so I think there's risks and benefits on kind of both sides. And I think the PCOS world has gotten really kind of almost divisive and really polarized on it. And I'm like, I think your practitioner should actually be completely unjudgmental and unbiased and not actually care what you choose. I think you should be presented the options, and what feels like the best choice for you should be the best choice for you. And a lot of that conversation should be centered about your contraception options, if that's important, and then your risk for failure on contraception options and where you land there completely separately and aside from PCOS, because some people will land on the oral contraceptive pill after having an informed thought process about contraception. And then if that's the case, like there's just more than one reason for it for some people.
Yeah, I think again, maybe I'm aging myself a little bit here, but when there was less knowledge about PCOS, young women were being put on it for period symptoms or period irregularity or acne without us tying things up together to acknowledge that we were actually supporting an underlying condition with that medication. And so people felt like they were maybe not misdiagnosed, that's not the right word, but like they missed having a diagnosis in their teens when, if they look back on their experience, then those symptoms had been there all along. Yeah. And it wasn't until they were in their 20s or 30s and decided to try and achieve a pregnancy that we were finally starting to look into their hormones a little bit deeper and then realizing that they had this like underlying hormone condition. I think the landscape has changed a little bit where when we see acne or androgenic symptoms in a young woman plus menstrual irregularity, we may still be giving her the pill, but we might be using the words, this looks like PCOS, where 15 years ago, that was not part of the conversation. And I think that that's maybe doing a better job of helping people understand the role of the pill or understand the role of solutions that we offer in adolescence, so that then when they are thinking about, their future hormonal health or maybe even their future cardiovascular health or what have you, they have that diagnosis from an earlier age versus them waiting until they're in their 30s for us to say, oh, this was PCOS all along. We just never told you.
I don't know if this is you or not, but if you're a naturopathic doctor or an integrative practitioner who prides yourself on being evidence-based, but don't have time to stay up to date with the research yourself, I have a solution for you. I'd love to invite you to explore and join the Confident Clinician, the only integrative medicine clinical decision-making tool that helps get research from PubMed into your practice with ease. We have built out exactly what you need to be the most efficient in your work, to be the best in your community, and to save you those precious hours that you're spending right now doing the research yourself. Joining with our premium membership gives you access to unlimited AI searches, gives you access to all of our previous database content, as well as our upcoming year of live delivered modules. You can check out more in the link in the show notes. I would love to see you inside of our community. We're making a huge difference in the way that practitioners practice integrative care and raising the bar for evidence-based integrative medicine. I hope you'll join us.
Mm-hmm. Yeah, totally. And like the guidelines, suggest like there should be some baseline testing at diagnosis, right? And so even in younger people, we're not waiting to do cardiovascular risk assessment in people with PCOS at just general population guidelines. We're doing it at diagnosis. But if that diagnosis doesn't happen, we're missing a big part of a big part of the puzzle if we jump straight there without that diagnostic workup and questioning, because then all of a sudden we might not be having the conversations about how lifestyle influences this condition. Because even if they choose the pill, it doesn't negate still wanting to work on the lifestyle skills that will help this person manage PCOS for the rest of their lives, and may even have a greater impact on their quality of life, because there's just really strong quality of life symptoms associated with lifestyle, where as somebody else might, do not a great lifestyle and be at higher risk of cardiovascular risk, but not feel it for 30 years. Someone with PCOS actually has symptoms that are affecting their quality of life from early on throughout their entire life. And so that is huge, and that's different. And I see a lot of like young people either not being assessed for cardiovascular risk, or it does come back positive and we see like high cholesterol, but it gets really dismissed. And it's like, but that might actually be a different conversation when we have a 20-year-old with high cholesterol and who will have high cholesterol for a long time, if not managed, than someone who starts having high cholesterol as an adult. So there's a lot of missed opportunities when we don't do this right.
So if someone has achieved that diagnosis, like in your opinion, what should their long-term monitoring look like? Let's say like it was all done, according to the book in terms of their assessment. We're like 99% sure we're talking about PCOS and it's the right thing. Now that they have that diagnosis and they maybe are not undergoing any like current acute medical care, say like we're not in a fertility setting, but we're just living our lives into our third, fourth, fifth, sixth decades. Like, what do you recommend and what do the guidelines say around like ongoing assessment of patients with PCOS?
Well, and I think, PCOS can look so different in different people. And so like, even though I'm saying like, well, when we compare a group of PCOS compared to a group that's not a PCOS group, we see these higher risk factors, but that does not mean it's going to apply to that every person with PCOS. And so it can feel a bit overwhelming, I think, as someone with that label to be like, oh, another higher risk thing. Great. But if we can explore them and have these thoughtful conversations, you can kind of understand maybe like what applies to you and what doesn't apply to you. And you can kind of let go of that isn't, part of it. So the guidelines definitely suggest that we do like a cardiovascular assessment at baseline. After that, it is based on your clinician, conversation about risk factors and probably your lifestyle risk factors that contribute in that. And so if somebody maybe screens as super low risk and has a really super low risk lifestyle, or maybe not checking as frequently, than someone who may screen positive right out of the gates, and then we might want to monitor what all of our tools are doing to manage that risk. And so we hear a lot of like buzzwords in PCOS, like inflammation or insulin resistance and cardiovascular risk, but we can actually kind of explore this with lab work and get some objectives to kind of actually have a thoughtful conversation with that person to see if this is something that should be on the radar or not.
Yeah, it's getting the data, right?
Yeah.
Rather than making an assumption about what's happening in your body. Because I mean, I'm always a fan of when there is appropriate lab work to do that we screen so that we can have these like thoughtful conversations with patients, and try and help contextualize. I think, when people get assessed or diagnosed with PCOS nowadays, it's very easy for them to see all the things that they're now suddenly at risk for, right? Or more at risk for. And I find a lot of that language can be quite fear mongering, right? Of like, you're more at risk for cardiovascular disease, you're more at risk for endometrial cancer. And like, we have to remember that like, although those things are true, what we're saying is the proportion of people with PCOS who have those outcomes or conditions is higher than the average population. But that's not like a set in stone, written down, like this is how your story ends kind of piece. But yet sometimes when we talk about risk ratios with patients, or they read about their own increased risk online, it sounds like it's a fact that it will happen versus it's a probability of it happening at a higher rate. How do you navigate that conversation with patients when they've been told or they've read about their higher cardiovascular risk and now they're worried about it?
We try to ground it on like real data, right? Like, and some of those foundational skills and nutrition skills and movement skills and stress management skills that have research in cardiovascular risk. I mean, the truth is like, as much as it sounds scary sometimes, right? Like sometimes the solutions are very close to one another. And so by supporting your cardiovascular risk, you're also supporting your inflammation, which is also supporting your insulin resistance. And so like, that is maybe the silver lining in all this, is that when we're looking at it from a lifestyle perspective, often these ideas that we talk about have more than one impact in a good way. And so that should feel just worth it.
Yeah, you're right. It's because there's that underlying, couple. I'm not going to say the couple of mechanisms because like PCOS in and of itself is quite complex, but like those couple of pieces that are happening hormonally / genetically are showing up maybe in different body systems, but have the same underlying mechanisms. And when people do work on those various areas of their health, or if there's particular nutrients that we know that make a difference, they are killing multiple birds with that same like treatment stone.
Yeah, absolutely. And I think that should be empowering and encouraging. Not to simplify lifestyle and behavior change, because that is obviously
It's a whole other thing.
And so, maybe that's another part that I just want to bring to light, is like, I know you mentioned the genetic components of it, and I'm so glad that you did, because, PCOS is not your fault. And there are genetic factors, and people in smaller bodies still get diagnosed with PCOS because of these genetic factors, and they still have, some of these symptoms, right? And so it can influence, but it's not your fault. And the part about the lifestyle conversation is like, okay, we see this being a powerful lever. And yet the conversation, I think that's not maybe happening out loud as much, is that people with PCOS are more likely to suffer like mental health, body image issues, and all of those other aspects that impact also behavior, right? And so I think that also, when we're talking about baseline testing, maybe I didn't mention it at that time, but I'm like, that's also the opportunity of diagnosing someone early, right? Is that you can screen for these things and support lifestyle in a way that's more body positive and more confidence building for someone over their life, because it's a delicate conversation.
So if someone was listening to this, Melanie, and they were now suspicious that either they themselves or maybe their daughter or someone in their family has PCOS, how would you suggest that they approach that doctor's conversation to get the most out of that interaction, assuming that it's a short wellness check type visit with their doctor? We'll talk about why they should maybe work with a naturopathic doctor in a second. But if you're approaching a conventional healthcare appointment and, time is of the essence, like, how does someone approach that appointment so that they get what they need out of it, and if they're suspecting a PCOS diagnosis?
I think lead with curiosity, right? I think just always assume the best of the clinician that you're working with, because I think everybody is doing their best. I just think some doctors are in systems that are hard to do a full PCOS diagnosis. And so I would say, like, the PCOS guidelines are easily available online, open text, and for free. And so you can print that diagnostic criteria and be like, I'm kind of curious about this because I see myself in this and this and this. What do you think? And it kind of gets you on the same page. It kind of grounds in something that they know has a lot of support for. It also, if they are less familiar with PCOS, just puts it on a silver platter about what are the exclusion criteria and things like that. And so I think it gives you your best shot at kind of getting it all in that visit. And so I think that would be the conversation that I would have. My personal experience was bringing it up to my family doctor. And at that time, obviously knowledge has come, like Wikipedia. Wikipedia did in front of me and was like, okay, I'll send you for an ultrasound. Luckily I was over 19, so it made sense. And so ended up doing the right things. But, if you print that first page or if you have the guidelines and just share and lead with curiosity, I think there's a really good chance it goes well.
Mm-hmm, mm-hmm. Yeah, I agree. I love when you point out that sort of like understanding and knowing what those sort of 3 points are for that diagnostic criteria, especially if you've done a lot of your reading or research about your condition online. There is a little bit, and there isn't research with PCOS per se, but there's a little bit of research that when we describe our symptoms in very, I'll say inefficient ways, right? And we're not to the point, or we use a lot of like metaphor to describe the way that we're feeling, right? Like if you say something like, my period is like a tidal wave, you actually are going to get less outcomes from that conversation than if you use the term, I have heavy menstrual bleeding, which sounds crazy because, for many of us that are talking about hormonal health all the time, we probably would use those two terms interchangeably. But that doesn't always mean that your outcomes or the testing you get translates into assessing you for certain conditions. And so the closer that you can frame your experience with in terms of those like 3 diagnostic criteria, certainly the more efficient your visit will be and the better it will be. I always hate making patients feel like they're responsible, right, for knowing this and going in with those things. I think that like you said, Melanie, the diagnostics has come so far and that more clinicians are well versed than they were 15 years ago about this. I think we're probably doing a much better job about it these days.
Yeah, totally. And it's just even like maybe a gold nugget would be like one of the really important data points is your cycle length. So let's just define that, because this is something you can kind of go home with. And cycle length is defined as day one of your period until the next day one of your period. That's your cycle length. It often gets confused with menstrual length. How many days did you bleed? But that's not what we're talking about when we're talking about irregular cycles and PCOS. We're talking about the entire cycle length. And also, irregular cycles has a very specific definition. We're not just saying like you're always 28 days and then you had a 30-day cycle and then you had a 27-day cycle. That's not irregular. And so that cycle length definition also changes based on your age. So I won't like set anything in stone, but the one maybe thing that I would like to everybody to be on the lookout for is, you mentioned the endometrial hyperplasia, right? And so if someone with PCOS is not having regular cycles, not having is not bleeding, that does put them at higher risk. And so the number you really want to set a clock to is, if you're not on the birth control pill, is 90 days. If you have not had a cycle in 90 days, that should be and you're not on the birth control pill, that should be a prompt to talk to your healthcare provider so that we can induce a bleed, because we can really reduce that hyperplasia risk. We just make it happen. And so that's what you need to know if you're not.
Amazing. This has been such great intel, Melanie. I haven't revisited this conversation on the podcast for quite some time. And I think, being reminded that diagnostic criteria shifts a little bit with age, I think it puts in perspective for people that were told they have PCOS on ultrasound in their youth, like maybe some elder millennials like myself who maybe would have been told they had PCOS as a younger woman and then grew out of it, right, as they got older. You may have never had it in the first place, and we just used the wrong techniques for you. Mm-hmm. It maybe gives some clarity for people who were put on the pill at a young age for symptoms that were seemingly not connected. And now we are connecting those symptoms to be related to PCOS. But hopefully it helps that the younger generation of women, I think, that are coming up are maybe experiencing this assessment and support in a slightly different way. Can you leave our listeners with like a final thought of how you want them to feel about what we shared and talked about today? And how can our listeners learn more from you and find you online, Melanie?
Yeah, great. I think the take home that I want you to leave with is like, I think there's a lot of messaging of like, reverse or stop. But if you've been properly diagnosed with PCOS, there's some genetic factors. It is for life, but I want you to think about it as like a dimmer switch, and like the things that you do can impact like the intensity of how the symptoms are manifesting for you, like a dimmer switch. And so it can be highly powerful and really have a huge impact on your quality of life. And I think that's why it's so important, in addition to changing risk factors. And so you're in this for life, right? If you've been properly diagnosed, you don't need to get there overnight. One skill at a time, one step at a time. That's always the way. And so not thinking all or nothing about it, and just trying to figure out like, what is your next best step right now, and taking one step towards that in that direction. Because the thing about PCOS, it also means you're probably going to feel better. You are actually going to get some of that benefit of that lifestyle in your symptom intensity. You can follow me on social at PCOS Health Collective or at Dr. DesChâtelets. And if you like kind of the tone of this conversation, and I'd welcome you to the workshop called Beyond the Pill, the 3 conversations I wish you had with your diagnosis. And so it's not about being anti or pro. It's about the conversation I just wish everybody had. And it is like a 45-minute workshop, and you kind of understand why, the 7-minute visit is like not set up to be able to handle that level of conversation. And so we'll provide the the link to that too. It's completely free, but if you like the tone of this, you might resonate with that too. So I think that's it. Thank you so much.
Amazing.
Yeah.
Thank you so much, Melanie. Yeah, we'll put the links to all of those things in the show notes, so you have a quick access back through your podcast player there. Thank you so much for sharing your insights with our community and offering them that free workshop to follow up with you. I really appreciate you and that we got to spend time together.
Yeah, absolutely. Thank you so much, Jordan.
That's it for today's episode of the Real Integrative Medicine podcast. I hope you're feeling inspired, informed, and ready to make changes that truly support your health. If you found value in today's discussion, don't forget to hit subscribe, share this episode with someone who needs it, and leave a review. It helps us reach even more listeners just like you. Your health journey is personal and it's powerful. Let's keep building on the knowledge to give you the confidence you need to thrive. It's important to remember that the Real Integrative Medicine podcast is for educational purposes only. Be sure to talk to your doctor before making any personal health changes. This podcast isn't intended to diagnose you, and no doctor-patient relationship was formed by listening. We'll see you next week.